but I don't know how much Yuvraj will be giving us. Case 1. Straight away we'll go to the case. I'm keeping the cases almost to basic. 72-year-old female. Can you have a screen there? Okay, right. 72-year-old female. Karthik. Start with Karthik. Oh, varliya. Okay, in the meantime, Karthik, you're. You are not seeing that, huh? Maybe why don't we sit here in the front otherwise? Inge, in the hall, front lab. Yeah. No, I can ask now everybody. I can ask Anup also. Yes. Anup, you're okay? Okay, Karthik, to start. So, this is a very common scenario, no, in our OPDs. Okay, so we have too much of alignments and all those things we were talking the whole day, uni and all those things. But this is the most common. So, in your OPD, when this comes, what will be your quick planning in the mind?
So, I need to examine this patient clinically. I need to know if there is an FFD and what is the range. And obviously in the X-ray I can see a gross varus and there is subluxation of the tibia. So in my mind I know that the medial side is tight and I should be careful of a lax lateral collateral ligament. So otherwise there is not much of bone loss. So but I should have a stem standby. I would just plan a routine primary TKR, most likely a CR.
CR. Sir, anything else, any investigation wise you would like to, sir? Rex, sir.
Maybe stress views can take to assess the collaterals and also long leg view, orthoscanogram.
So this is the long leg X-ray. So all these kind of cases, so much of deformity due to subluxation of this thing. Apart from this, the most important thing is again the preoperative planning. Yuvraj, any other in your mind you will like to think or plan in this?
So in this situation, I would like to rule out is there any stress fracture in the proximal tibia. These kind of patients, they have a risk of developing a stress fracture working with such kind of varus with the lateral subluxation.
Okay.
Yeah.
So anything in regards to implant choice, Muthu?
Yeah, obviously, if you carefully look at the X-ray AP view, there is a subluxation. This type of subluxation, it shows the laxity. Without much bone defect, there is a huge laxity even on the medial side. You should be very, very careful. So the gap is going to be big, and you will end up in big insert and may need stem. So even you have to keep the revision implants on the backup, and definitely, obviously, you have to rule out the stress fracture.
Dr. Satish, anything you want to add?
Nothing specific. First thing, all patients, you have to rule out diabetes. That is the number one. If HbA1c is more than 8,
yeah, in this case, all those.
I'm just telling you for the juniors, if HbA1c is more than 8, you have to straightaway postpone. Otherwise, the chance of infection is high. So here, we have to do medial release. So we will end up with a bigger gap. So we have to take a little bit less tibial cut. And I will always do PES. Because it is always sublux. The tendency to again resublux is more. So PS is better. And take less tibial cut because after releasing the medial release, there will be always some gap.
Dinesh, one more mic there to Dr. Anup.
And obviously, in this case, you'll expect the flexion, extension gap, both will be huge. So the laxity will be more than the defect. In other type of varus, you'll get huge defects, posteromedial defect or medial defect. The posterior half of the condyle will be defective. In that case, the moment you fill the gap, you'll get the balancing. But in this case, it is going to be big laxity, so you have to be very, very conservative in your resection. Cut less and fill the gap with implants.
Yeah. Anup, anything you would like to add apart from these points from your point of view?
So the challenge here is lateral laxity, especially on the right side, which is subluxed more than a centimeter. The left side will come nicely after we remove the osteophytes. It will more or less fall back into place. But the right side may need some restrictions on KA, but the left side can be done with KA.
Okay. So right side you won't do a KA in this. Am I correct?
No, left side I want to do a KA. Right side I'll see. It will need some restriction of boundaries on the right side.
Okay.
Another one point here, if you see on the AP X-ray, there is a defect on the lateral condyle as well in the femur. That shows that there is an entity called varovalgus knee. So the knee is in varus in extension. As you flex the knee more, you'll get valgus. So obviously, if it is 30-degree varus in extension, at 90-degree of flexion, you'll get 30-degree of valgus. That is explained as varovalgus knee. Dynamically, if you see, from 0 to 90 degree, the angle axis changes. When they walk, when they move, when they walk in 30 degree, 45 degree, 90 degree movements, they'll have laxity on the medial side. Okay. It's very, very important. Varovalgus knee. And you can see this sclerosis, all these things.
Yeah.
Even intra-op, you can see that the sclerosis and defect on the lateral side, post-lateral corner, there will be a defect. Sclerosis will be there. Some bony defect will be there.
So these kind of cases, gross subluxation, severe varus, actually it may not be that severe varus. The contracture, what we talk usually about, all this soft tissue contracture, all those things may not be there, but it is the subluxation and the soft tissue laxity, but the medial collateral may not be. So for that, definitely the stress views, whatever might be, to start with, all manually, conventionally doing TKRs, these kind of cases, the stress views help a lot. So it has to become a routine in our practice. So now in this case, if you see, you don't need much of release at all. So actually speaking. Now Anup, will you change now your plan about the kinematic, conventional kinematic?
Yeah, so as I said, lot of decision making is taken after anesthesia on the table.
Yep.
And this seems to be, this can be done with KA, there is no problem.
Yeah. So that's what. So this alarming X-ray like this, which thinks us to have a lot of constrained processes in hand, but it's not bad to have it, but still this X-ray itself gives us a lot of information that not much is needed in this primary TKR, totally replacement. Whether a CR or a PS, that doesn't matter. So the primary totally implant itself is suffice. So that's what the case is. So just yes.
In the same, the kinematics can be seen in 45 degree and 90 degree also. The X-ray what shows a stress view taken at full extension. If you take it in 45 degree, 90 degree, that balance, the laxity in the medial and lateral sides on flexion also will be visible.
Yep, that's a good point. Yes, okay.
We did it as it gives a lot of information. Exactly what to tell is to nothing you need. It's completely balanced.
Most varus knees correct, auto-correct in flexion. And if you see, say, 15 degree varus, in flexion it will be 1 or 2 degree, 3 degree valgus. So flexion, you don't need much release or anything. You just need to take the bony cuts appropriately.
Definitely.
Beautiful done.
Thank you. So majority of the time we need the planning, that appropriate X-rays gives us a lot of information. At the end, whether you do conventional or a robotic, proper balancing definitely solves almost all the problems. And also the component placement also plays a role. See, sometimes this slightly undersizing the tibial tray, accordingly you plan the femoral component to match it, and then the reduction osteotomy. These small tips, procedures helps us in getting the right achievement, rather than thinking of too much, resecting too much, and then putting a bigger insert, adding stem. All those things can be avoided, considering this as a primary knee to conserve the bone for the next procedure. So that must be the message.
But beginners can have backup?
No. See, backup is definitely not a harmful thing. Can have it, but that should not be the driving factor for additional procedures. Just because a backup is there, they should not think of. So they should stick on to the principles and basics, so that they always end up with the primary and the basic thing. Okay, 30 years back, this patient had an RTA, had a proximal tibia fracture, managed conservatively, diabetes mellitus, but all under control. Now pain in the right knee, and this is an X-ray. Karthik? So,
This patient has joint space reduction medially.
yep.
And
Other findings, quickly?
I can see some changes in the patellofemoral aspect as well.
Okay.
And obviously there is a malunion, or we can say a united fracture in the metaphysis, the proximal tibia. So now
No, definitely there is arthritis, medial compartment OA, proximal tibia, there is a fracture malunion, okay, there is a deformity. So this patient needs a total knee, definitely. Sir, like in your, now you are also doing robotic TKRs. So in this case, you will do a robotic or a conventional?
Yeah, 100% will do a robotic surgery, but I'll do a orthoscanogram to find out how much the varus and extraarticular deformity is in the three-dimensional way. And I feel it's acceptable values will be there to do an intraarticular correction. And providing a stem is not really necessary, because if he's walking and the bone quality looks pretty good, I'll keep it as a backup in case. And we'll do the robotic.
So you will do a robotic. Yuvraj?
though, can I just
The challenge in the
one thing I want to add is these sort of malunions or old fracture unions, there can be sclerosis where you can't get your keel inside your normal keel. So I would probably get a CT scan just to make sure, and I will keep a burr handy so that I can actually.
Yeah, these are all definitely, yes, good tips and tricks which you can have it in the theatre as an additional thing. Any entry point becomes difficult, you will need extra drill bits and burrs that will help you to make the entry. Yes, Yuvraj?
challenge in this case is the
Yeah.
skin condition. We have to assess pre-operatively, especially in the
What is
post skin condition.
Yeah.
Especially-
So
sometimes
take it,
there'll be-
all those things has been worked up.
Yeah.
Patient is ready for surgery.
And usually they have present with a stiffness. Post-traumatic stiffness is a common issue.
He had a
Exposure-
reasonable flexion, good almost 100 degrees of flexion.
And when you have exposure, the risk of patellar tendon avulsion is there, so you should be a bit careful,
Yes,
especially in
that is a good
post-traumatic arthritis.
Good.
And you might have to keep a backup for offset stem.
So I know you, this extraarticular deformity,
Okay.
how will be your approach? Anything special you want to do in this?
I think this is not, it can be corrected intraarticular.
Okay, that is the point. Okay, yeah.
Obviously, you can correct it intraoperatively. It's not a huge deformity.
Yes. Yes, Dr. Satish, anything you
Tibial
want?
alignment, I will do intramedullary jig and then tibial cut. That can give a better cut. Rather than extra articular, I would like to give a intra-articular guide and then cut. That is the only thing what I want.
Any infections, sir, before?
No. All those things ruled out. So yes,
Yeah, this patient has had a recurvatum deformity or upslope on the tibia and the sagittal view. So in case you are doing a CR knee, if the PCL is intact, don't give it too much slope because it will going to cut too much.
Yep.
So your slope even for a CR knee in this case should be 3-4 degrees.
Anything else? This you will use a robot or any kinematic?
Yeah, kinematic can be done because the knee is not subluxed and the deformity is well within 10 degrees. And robotic will give us very good assessment of the slope of the tibia and recreating that slope.
Yeah. So that slope issue is probably due to the malunion has happened because of the fracture. So the whole posterior condyle has gone in the reverse direction. So that is a good point. So these are the things which we have to plan it pre-operatively, we are going to deal with. I know definitely this can be tackled with a conventional regular total knee replacement. That is a acceptable thing. But these are the important points. The sclerosed bone, what everybody mentioned, the lytic areas inside the proximal tibia which you have to deal with. Suddenly that might have a crack, then the sclerosis, then the slope, then the recurvatum. All those things has to be considered and kept in mind while doing the surgery. So yes, this was like, if you look at all these angles, almost within the limit of doing an intraarticular correction. So if you look at this is actually, I made it for the youngsters. When you draw this Cora angle, if it is passing within the tibial condyle, you can majority of the time do an intra-articular correction. So this planning definitely is a must in these kind of extra-articular deformities. This is a simple extra-articular deformity which was managed intra-articularly. So even though this was not extra-articular correction has not been done, just with a simple intra-articular correction, the alignment has come to this level. So that is what the preoperative planning. Suddenly, just because it is an extra-articular deformity, we need not go and do a two-stage procedure or anything. I added a stem here because of the weak sclerosed bone and lytic. There are small lytic areas in the proximal tibia. So that made me a little worry for just a regular total. So I added a stem here. So patient did well. This is an post-operative alignment X-ray, and 1 year follow-up. He was doing well, walking comfortably. After 1 year, he again had an RTA, two-wheeler versus another some RTA. So injury to the right leg, and this was the one. Yes, Muthu, now.
Yeah, obviously you have to treat like a normal tibia fracture. You can't do nailing. So implant is stable, I feel. Implant is good, looks stable. So simply like a periprosthetic fracture.
No. What implant you want to do? I know it is needs fixation. I know
Obviously.
it needs plate. What exactly? What will be your choice? Implant choice.
You choose the best plate to get bed purchase, maximum screws proximally.
Locking plate.
Yes,
Locking
you're right.
obviously.
You're right.
Locking derotation. Locking plate. Yeah, locking plate.
Variable angle plate, which variable angle plate, so that you can get your screws in
Yes,
front. and the
obviously.
back of the
Maximum
tibia
screws.
So now
same.
Maximum length.
Yeah. So for everybody, the information I wanted was whether you want going to use a 4.5 regular DCP or a medial plate or a lateral plate, like that.
No,
Yes,
obviously.
Karthik is a.
Sir, I'll give him the option of conservative treatment
See?
versus.
That is what. See the answer. Good. So you want to do a conservative. Why conservative is contraindicated in this?
Well, because there is a joint up there, I'm not sure if it is contraindicated as such.
I will say definitely it is a contraindication.
Oh, then
It's
you'll
an
have
operated knee.
Yeah,
Knee,
I will
operated
say, yeah.
knee, it will become very stiff.
No, why one point, that's I wanted.
We
for
treat a lot of periprosthetic fractures in the shoulder conservatively. And
There is fibula fracture also.
Yeah. A comminuted fibula fracture and a mid-shaft fracture at the same level. That's why it's a high energy trauma. So that is the only reason. Otherwise, yes, definitely.
No, tibia fibula is not a contraindication for conservative management.
With
It
an
will heal.
implant.
Or you can put fibula KVR and you can treat conservatively POP. Fibula can be stabilized with the intramedullary fixation.
Okay. So let
And the
us.
tibia will get aligned.
Okay,
40%.
anyhow, you can treat both also. So definitely conservative also, it will unite. That is not a question. Whether it unites.
Conservative is not an option according to me because even minimal degrees of malignant will result in implant problems.
Yes.
So conservative
yes,
is
obviously.
not acceptable. We have
Yes.
to get
You have
proper.
to get
It will
alignment
change
to-
the alignment
Otherwise,
actually.
the problem will happen in the joint.
That is
If it
the
is
reason.
go
You
for
have
a
to accept the
malunion,
alignment
So
to
change
preserve
the
the
variable angle locking plate, that is the choice.
Okay.
Long Mipo
Medial
type
plate
of
always.
plate.
So always
laterally.
go for middle side and so you need
My
need support
choice
from
is
both
always
sides.
medial, yeah.
Yeah, so anyhow, this was the tibia fracture was not that comminuted, so we didn't want to add a lot of plates because already an implant is there inside, and the patient soft tissue was also compromised. So adding so much of metal wear, so it was a very stable construct. So also patient had a medial malleolus fracture which was fixed, and 1 year patient it was united well and
Yeah, nice.
doing. So the whole point here is it needs a stable fixation. So periprosthetic fractures are more common, particularly after a road traffic accident following a total knee. So we have to be prepared for that also. It's that is the only. Okay, 40-year-old female, known juvenile rheumatoid. Okay, so I started with the left THR, then left TKR, then right THR, all the 6 years, 3 years. Now pain and deformity in the right. These are the other X-rays, both sides did. Then I did the left side. Then now the right side. Dr. X, sir. So this is she's young, 27. She's only 27, and this is the right side, valgus knee.
Yeah, the valgus knee with a lot of osteoporosis.
Yes.
And is it stiff valgus?
Almost, yes,
Looks
like a
like-
very restricted movements.
Yeah, looks
Not
like stiff.
completely stiff, but yes, definitely movements are restricted.
And also the patella is subluxed to one side. And I would expect some additions on the suprapatellar pouch. The movements will be very less. So you need to do a good preoperative planning, do a long leg view to see how much the valgus is.
Long leg.
Yes. So gross valgus. Normally we'll do a conventional total knee replacement with a medial approach. Lot of lateral release need to be done, but I'm very happy to go by the medial parapatellar rather than a lateral parapatellar. And the IT band and the lateral structures, the popliteus and all those structures, we need to have a good release. There may be posterolateral defect, which we need to assess a bit more to see how much the bone defect on the lateral femoral condyle. And I'm sure the straightforward PS knee I would do here.
Dr. Satish, anything more you wanted to add, and your challenges in this?
The challenges is always the patellar maltracking is a challenge, and severe osteoporosis is another challenge. The medial side bone will be extremely osteoporotic. So my preference will be to go on the lateral side because there is a
So you will do a lateral.
documented patellar maltracking pre-op. The moment you correct the deformity, the maltracking will only increase. If you have corrected the deformity, the maltracking will increase. So you have to do an extensive lateral release if you go by the medial approach. So we will go by lateral expansile approach, quadriceps nip, and then we correct the deformity. You can have femoral stem in hand because the femur seems to be very osteoporotic. There is a chances of
Yes.
prosthetic fracture.
Good
very
points,
prosthetic
yes.
fracture.
Anup? Yes.
In this kind of valgus knee, always document the foot deformities, especially in the MCL insufficiency will be there. Unless otherwise, if the patient has a pronation type of foot deformity, they could present with a late instability. So always you have to support post-surgery. That is one point I would like to add. Is a regular, as Dr. Rexa said, medial parapatellar approach with standard Ranawat inside out release, PS knee. I would like to resurface the patella in this case because maltracking is there. That will be helpful to give a good tracking post-op.
Yeah, Anup?
Yeah, so we do bone density in all our cases, but this patient definitely we should do a bone density. In case we are adding a stem on the femur, it has to be a short stem because the long stem will go very near the total hip implant. So wherever we have a total hip up there, we should use a short cemented stem, though I don't think it will be required. Rest is a standard correction of valgus knee. I would still choose to do a cruciate retaining or ultra congruent type of to prevent a big box cut.
Karthik, anything more you want to add?
So I would be happy doing a lateral approach and do a routine knee, sir.
Okay, right, good. So, what here for me, I think everybody mentioned about all the points here. For me, the biggest worry was the patella. So I will say it's not a maltracking, it is almost a dislocated patella, almost, because the patella is articulating with the femoral condyle, not on the trochlea. So that was the big challenge, and the osteoporosis. So these are the two things. So what I preferred was a lateral parapatellar arthrotomy. So because I knew that even if we do a medial, we need to do a lateral retinacular release to bring back so much of laxity on the lateral side and on the medial side, and then the contracture. So all those things I preferred a lateral parapatellar. So this is what parapatellar arthrotomy, and then after the arthrotomy, I found the patella was too small and thin. It was almost like excavated, huge defect. So I was like, initially itself I did a patelloplasty to make sure I'm not damaging the patella during the procedure because it's a lateral parapatellar. So then after that, lateral parapatellar, this is the bone loss, and then proximal tibia was small and rotated. So I had to be very, very careful in placement of the tibial tray. The smallest tibial tray size, 1.5, was I selected. And in a valgus knee, there is a remodeling in the proximal tibia. So for that, I need to compensate, used the extramedullary guide to get my rotation correct. And then after that, this is after the trial processes. And I didn't, without any other further release, no quadriceps snip or anything, Just the lateral parapatellar arthrotomy and the correct placement of the implants made the tracking very good. So I didn't have any issue with the tracking. So additionally, the only issue is the closure of the medial lateral side. It has to be little careful because you have opened it out, you need that soft tissue cover. So gently I had to pull this after cementing the original processes, and I had to use the Ethibond for closure because I had to plicate the medial side, and the lateral side again I used the soft tissue, little bit of fat here and there mobilized, and then somehow I was able to close the implant without issue. And this is the post-operative, after the closure. And for the osteoporosis, it was almost like a powder, the implant bone. So I just added a stem in the tibial side, and the femoral side I didn't have any issue. Yeah, I didn't have any issue. So this was this was POD 3. So at this stage, anything you would like to do, Anup? This was POD 3.
Just like to watch. I think this is lateral parapatellar hematoma.
Yep.
So this will just need a careful watch.
Okay.
And some icing and should be okay.
So that's a good point. So this should not alarm us and say, okay, something infection, so we should not be pumping in and too much of antibiotics. But it got increased in the POD 5. So I'll quickly go through that what I did. So I stopped all the anticoagulants, the ecosprin, what we usually give, stopped it. Stopped all the CPMs and the knee bending exercises, put them on the rest, just prophylactically started on antibiotics. 2 weeks follow-up, patient started resolving. So then slowly started healing, then started on active bending, and this is the 3 weeks post-op, and after that the skyline view also showed how good the alignment and everything, and then this is a 2 years follow-up.
I think the skin incision has to be slightly lateral to the center to avoid this. If you are doing lateral parapatellar approach, the skin incision should be centered on the center of patella. That will be, it will come more lateral so that the lateral flap is not big.
Good, thank you.
So one more question, what is the youngest knee replacement done by you? Youngest
Hip
for
replacement 14, knee replacement 18. Rheumatoid.
Okay, great.
Thank you.
I did for 24 years female, so I wanted to recheck.
I'd like to invite Dr. Anup sir to give his recorded live on kinematic alignment, following which Dr. Bende sir is waiting there. So, no, he's waiting there. So you finish it.
Finish in 10 minutes, 10, 12 minutes. Basic principles.
I'd like to invite Dr. Rajkumar sir to moderate the session with
So,
Dr.
let's
Mukesh
go to the
and Dr. X to moderate the session.
slide. Okay. All right. So let's see the X-rays first. This is a standard varus knee of about 12 odd degrees, and we are doing the left side. So there you can see we have calculated the MDFA and MPTA, and as I was saying, MPTA could be quite erroneous. So we have to look at intra-op landmarks, and it's also important to calculate the slope of the tibia and replicate the slope of the tibia. In this particular case, it's 8 degrees. So our aim and objective is to do a kinematically aligned knee with the help of QVIS robotic system, and I'll show you how it's advantageous because you can actually calculate the distal lateral and the distal medial cut and the posterior medial and posterior lateral cut. And if you can see, there it is distal lateral 9.1, distal medial 4.7 at a valgus of 1, posterior lateral 9.3, posterior medial 8.3. So we are giving equal cuts after accounting for bone loss. And the flexion of the femoral component, we often don't talk about it, but it's very important, very crucial to keep it between 3 and 5 degrees. Once we have planned our femur with a size E, we can plan our tibia. You can see that the tibia is in varus 2 degrees as a starting point. We can increase if required, but in this particular case, we thought that 2 is pretty okay. The slope is 6. Why it is okay? Because you can see here that the lateral cut is 6.1 and the medial is 4.3. So once we account for the cartilage loss, it's equal cut. So basically, equal distal lateral, equal distal medial, equal posterior medial, equal posterior lateral, and the tibia cut equal from the tibial spine. Once we get that right, there is no need for any ligament release. So there you can see that we have exposed the tibia, exposed the knee, and the center of the knee is not the interepicondylar axis. The center of the knee is where I am passing my pen through the center of the condyles. So if you draw 2 circles in an MRI, it will pass through the center of the condyle. The interepicondylar axis has practically become irrelevant as far as kinematic alignment is concerned. Then you can see there is an offset on between the tibia and the femur. An offset is about 10 millimeters, and that needs to be restored. Then finally, the internal rotation of the tibia on the femur, and you can see that the tibia will internal rotate on the femur. So there are 6 axes of movement. We have just been focusing on the flexion extension. You can see tibia beautifully internally rotates in an ACL deficient knee. There is an offset to the knee, and we need to replicate, reproduce these kinematics of the knee in all 6 degrees of rotational freedom, not just the flexion extension. Once we have done that, then we put the arrays. Now, this is an important concept that in mechanical alignment, which is the red line, you are cutting perpendicular to the mechanical axis. The green line, the kinematic alignment, you are cutting in valgus, whatever is equivalent, cuts equal medial and lateral. Flexion of the femoral component is between 1 and 3. And tibia, you can see the red line is the mechanical alignment, the green line is the kinematic alignment. So you start with 2-3 degree varus and avoid any ligament release, especially pie crusting or downsizing of the tibia and using a saw. So once we have done that, the next important principle is that there is no need to rotate the femur 3 degree. Your rotation is equal posterior medial and posterior lateral. And there is no need to lateralize the femur also. Centralize the femur is good enough. Then we register the points and the femur and the tibia. There are about 40 points which need registration, and once all the points are registered, then we are ready for the gap balancing, which the robotic system will show us. So you can see it's extension 7 and medially it is tight. So it's 1 in flexion, as sir was pointed out, that most knees correct themselves in flexion. So here the gap in flexion is nice. It's 10 and 8, the way it should be. And the lateral gap should be 2 millimeter more in flexion. So 8 and 2, when we remove the osteophytes, it will become 8 and 8 or 8 and 7. And in flexion, it will be 10 and 8. So that's the way your gaps need to be. Now after that, we put our clamps and allow the robot to do the job. Of course, we have to be very cautious, very careful, very cognizant of the soft tissues. And then the robotic system will burr and the last principle is that we are not chasing a straight HK, we are chasing balanced gaps in extension and in flexion, a trapezoidal gap. Now, this is the distal femur cut. Then this is the anterior cut. It's a fully active robot, but you got to be careful of the soft tissue. It's very accurate. But still, having said that, you need to be cautious and careful. And then the posterior cut, and because it's a CR knee, there is no box cut. So we are eliminating not only one step, but saving the very important posterior cruciate ligament, which will give the internal rotation of the tibia and the femur and will facilitate patellar tracking. So patellar tracking, as has been talked, is not dependent on 3 degree external rotation, but is dependent on maintaining of Q angle, retention of PCL, internal rotation of the tibia on the femur, which takes the patella very harmoniously on the trochlear surface. So that's the tibia cut. And then we check all the cuts. So you can see that rotation is 3 degree internal and flexion is 3 degrees, exactly the way we planned. And so is the tibia cut. You can see the tibia cut is also in about 2 degree varus. We can increase the varus if we are tight medially, but avoid any ligament release. Now we use a laminar spreader, remove all the osteophytes medially and posteriorly, and not do any ligament release, including the PCL and the retinicular ligaments. Once all that is done, we see a trapezoidal gap in flexion. This is very important. Normal trapezoidal gap is maintained with kinematic alignment because you are not taking off the PCL, you are cutting in varus, so your normal trapezoidal space in flexion is maintained, which will allow for a nice rollback. Removal of all osteophytes. We don't go around the tibia with a cautery. So after the midline, we don't touch the cautery. Just remove the bone, whatever can be removed with a nibbler. After that, don't use a cautery to go all around the tibia and cause instability patterns which are very subtle in nature. Now, we need to get full extension of the knee. You can see that the knee is fully extended. Actually, 1 or 2 degree hyperextension is what we like because you can see that the gap is 10, 7, and I can't see from here. Okay. So, knee is fully extended, and what we are trying to demonstrate here is again the internal rotation of the tibia on the femur. So knee is not a uniaxial joint. You can see complete extension. 1 or 2 hyperextension is desirable because we have not done any soft tissue release. The PCL is intact, so it's not going to stretch out. If you give fixed flexion deformity in a kinematically aligned cruciate retaining knee, it won't correct. So 1 or 2 degree hyperextension is a must. Patella will track beautifully. You can see that the patella will track right from the onset of flexion and the tibia, and you can see there beautiful rectangular extension gap, no laxity at all. No laxity. If there was medial tightness, you can go for slightly more varus cut. And there you can see internal rotation of the tibia on the femur, beautiful 10 to 14 degrees, and this in turn facilitates patellar tracking. So these are the principles of kinematic alignment, and then rest is the cementing part. But friends, ligaments are not tight. Our cuts make them tight. So please understand that we have to restore the valgus on the femur. The rotation has to be 0 and the tibia has to be in starting point 2 to 3 degree varus, and 90% or 80% of your varus knees will correct beautifully by retention of PCL and not doing any ligament release, not going behind the tibia at all. So those are the basic principles of kinematic alignment. Thank you for your attention.
Thank you, sir. Sir, please, any questions from the floor? So regarding how to balance the knee without a ligament release. Thank you, sir. Thanks for a good demonstration.
Anup, so this with the robot, so if you were to do without the robot, is it the same this thing you follow?
It's the same.
Almost the measured resection, am I correct?
I will at least use navigation. I will not do manual. I don't do it. Yeah. But you can, but you have to, Rajkumar, you have to really measure the cuts very accurately. Because otherwise you will not be able to maintain the normal joint line. And then you will have abnormal laxity or stiffness.
So the message why I asked this question was, the message should be any altered alignment we try, it should be a technology assisted. So
yes, as far as possible. Yeah.
So one more question is regarding the joint line orientation.
Yeah.
And how do you control this? Because some apex down, apex up, all those things, how do you take into account?
So if you look
try
at,
to reproduce the same.
if you look at Drawer Pelle's work, and for a moment forget about CPAC, which is quite recent and describes the knee, arthritic knee. If we look at normal knees, we have done a study and you can do it. So normal MPTA is anywhere between 83 to 85 and normal MDFA is between 91 and 93. So that should be our starting reference point in most varus knees. Here or there 1 degree. So I don't think we should be chasing CPAC, which is just a coronal classification and says nothing about axial or sagittal plane of the implantation.
Limit of your
of the pre-arthritic varus? Or the cuts, limits of the cuts.
Limits of the cut.
Yeah, so usually we start with 3, maximum we have gone up to 6 degrees of varus on the tibia, but that's very rare. 85% of cases can be handled by about 3 degree varus, maybe 5% can be handled by another 1.5 degrees. And usually that should be your, that gives the very good extension balance. After removal of osteophytes, see, we should not be calculating. CPAC does not calculate the effect of osteophytes. It says nothing. It's silent on osteophytes. And osteophytes determine all the laxity and all the change in the gap measurements. So once you have 2 degree varus, you remove all the osteophytes. If you are still tight, you can take a degree more and you will be beautifully balanced.
So thus your preoperative scanogram values decides on your tibial cut varus, or your intraoperative release and the robotic assessment gives you what is your exact varus.
No release, just measuring the cut from the robotic arm. We saw that it was 6.5 and 4.1 on the lateral and medial side respectively, accounting for the bone loss. So you can start with 6.5 millimeters and increase 1 or 2 millimeters based on the tightness or laxity of the knee. But femur is not negotiable because the center of the axis of the knee passes through the femur. So femur is not negotiable, tibia is. Sorry?
So this is perfectly fine in the patients where there's a significant varus without much of a posterolateral laxity. In case there's a significant laxity, maybe requiring semi-constrained backup, something of lax of that kind of knee. So what will be your
surprised that our use of a PS and a semi-constrained knee, which was very common, every 1 month we would put a constrained PS knee, has almost gone to zero. Because we are aligning our knee and balancing our knee with a CR insert. Not to say that if you have too much of posterior lateral laxity, if you have, then you need to take your tibia cut in more varus and then maybe downsize and remove some more medial flare of bone. You can do that. But there is no formal release or there is no MCL pie crusting as far as possible. So up to 15-17 degrees it is good. After 20 degrees, then you had to add certain restrictions, certain boundaries.
What is the maximum laxity you will accept on the lateral side?
1 millimeter.
Both in extension and flexion, sir?
No, in flexion it will be 2 to 3 millimeters because in extension it will be 1 millimeter.
Okay. And just to add to the point, sir, the CPAC MACDC group has recently published a paper regarding the sagittal and the axial angles, and they had concluded that there is no categorization based on these values.
I read that paper, yes.
That's it. Thank you.
Yeah, but knee is more 3-dimensional rather than a picture diagram.
Exactly, sir.
Knee is very 3-dimensional structure and anatomy.
So one last question regarding the tight medial side. You've done a varus on the tibia, and do you tend to do varus on the femur as well?
No, never. Femur is never in varus until and unless your MDFA is showing a 0, then I would take a 0. Okay. Because MDFA calculation is pretty much accurate. MPTA is not.
Okay.
So in case it is, if it's a, let's say a horizontal joint line, a tall male patient with horizontal joint line, a 90-degree MDFA, I would not hesitate to cut equal.
Okay.
And take a 0 degree on the femur.
Femur, right.
But not in an effort to open up the medial space. That's not right.
Okay, that's fine.
Because you're taking varus cut on the tibia, so you cannot do that on the femur again. So it's going to open up the...
No, just what I'm asking for. Opening the middle side, you tend to do sometimes. Right.
Yeah.
Thank you.
Thank you.
Thank you, sir. Thanks a lot for your well-described technique.